Right now, Blue Cross and Blue Shield companies are committing more than $7 billion to fight the COVID-19 pandemic, providing premium relief, enhancing access to telehealth, and investing to support people in need to bring security and stability to the communities we serve. Rising to meet the challenge for the health of America.
Welcome, and thank you for joining us today. I'm Justine Handelman, Senior Vice President of the Blue Cross Blue Shield Association. All of us in healthcare have had a singular focus for the past year, battling a historic pandemic that has claimed 500,000 lives, caused a brutal economic downturn, harshly exposed the race-based disparities in our system, and upended our daily routines. So we're meeting virtually today, and I do know everyone is wary of screen time, so we really do appreciate you joining us for this important conversation. Today, we are going to hear from true leaders in this effort. I believe Dr. Cameron Webb, who has been on the front lines in addressing racial disparities and has been so much a part of this crisis. He is now a senior policy advisor for COVID-19 equity on the White House COVID-19 response team, and we're hoping he will be joining us today. We'll also hear from our plan colleagues in Tennessee and their partners at Meharry Medical College, who are working together on a groundbreaking program to address vaccine hesitancy. During the panel portion of the program, the chat function will be open for your questions, so we encourage you to use that. But first, we're going to hear from our new leader at BCBSA, our president and CEO, Kim Keck. Kim came to the association after serving as president and CEO of Blue Cross Blue Shield of Rhode Island, where one of the areas she focused on was addressing social determinants of health. She is absolutely committed to building a stronger, more equitable healthcare system for everyone. So now, Kim, please start things off.
Thanks, Justine, and thanks everyone for joining us virtually today. I, like Justine, wish we could be in person, but appreciate you taking the time to have a conversation with us today. So as Justine mentioned, I've been with the association, gosh, I think this is, if it's March, it must be starting month 3, so 2 full months, excuse me. And in that time, I've been certainly meeting with your members, been meeting with leaders in the administration, really to get to know everyone as well as we can do this remotely. But learning, importantly, how we can work together to improve healthcare and the health of all Americans. I know we share that goal. It's been clear in all the conversations I've had to date. But of course, here we are, good news today on the vaccine front, but still we are in the midst of this deadly pandemic. And our first priority, like you saw in the commercial in the video we just saw, is really to help get the disease under control, right? It's about getting the care that people need. It's about getting people vaccinating and helping communities weather this crisis. As you may have seen in the video, to date, Blue Cross and Blue Shield plans have invested more than $7 billion to address the pandemic, and we're not done. We're putting resources, our data, our people, our community ties to quickly and equitably bring life-saving vaccines to those that need them the most. More specifically, here's just some examples of some of the things we're doing. So we are using mobile clinics, we're using millions of Lyft rides for low-income uninsured people to get vaccines directly into underserved communities. We're paying our clinical and administration staff to volunteer to put shots in arms, schedule appointments, enter information into vaccine registries. We're offering our facilities everything from parking lots to retail centers so that we can have additional sites to get people vaccinated. And importantly, you'll hear more about this in a moment, we're addressing the issue of distrust, right? The legacy of distrust in the healthcare system on tackling vaccine reluctance is not an insignificant issue, and particularly not in the middle of a pandemic. So our team in Tennessee will talk about the things that they're doing to lead in this effort, and really at its core, get at vaccine competency and adoption of getting shots in arms. As I said, we're committed to ending the pandemic. We are really excited to see that Congress is working partway through, right, on the next COVID relief package. And we think there's a few things that need to be done, and so far so good. We think, right, at first and foremost, we need access to both additional COVID-19 testing and contact tracing. We're still not doing enough, in my opinion, on those issues well into, I guess, starting our year number 2 in this pandemic. We want to promote access to vaccines, as we've said a few times, that are equitably distributed. And we want to ensure that hardworking families get to keep the coverage that they have. As I mentioned, the legislation, I think, does a number of these things, right? I think so far we've seen monies that provide much needed funding to help states on the testing and vaccination front. We've seen the COBRA subsidization, right? Subsidizing COBRA coverage for those who have lost their employer-based insurance, expanding tax credits for purchasing coverage on the Affordable Care Act marketplaces, and then closing the low-income gap, the coverage gap, which is of course critically important during this time where so many are hurting from the pandemic. Having said that, there's still much work to do, right? We have some near-term deliverables, and those are great, but we're here to partner to build a more equitable system of health, including expanding access to coverage and ultimately lowering the cost of care. But without going any further today, since I hope we'll have an opportunity to speak many times throughout 2021, I'd like to turn it over to Dr. Cameron Webb, who, besides teaching at the University of Virginia School of Medicine, has been on the front lines caring for patients and also working to address racial disparities that have been such a big part of this crisis. Dr. Webb is also Senior Policy Advisor for the COVID-19 Equity to COVID-19 Equity on the White House COVID-19 response team. So we're so grateful, Dr. Webb, you could join us today, and I will turn it over to you.
Thanks so much, Kim. It's always exciting to hear folks in leadership who have that background, that insight, and that perspective on social determinants of health, because as we know, that's really where health is forged in so many ways. And this pandemic has shown us really in unprecedented ways the impact that those different factors have. It's really my pleasure to join you all this afternoon for this conversation and to just talk a little bit about what we mean in the administration when we talk about COVID-19 equity and how we're executing on that. As Kim mentioned, my role prior to coming to the White House, I was the Director of Health Policy and Equity at the University of Virginia School of Medicine. So I've been doing work in this space for a while, and even prior to my time at UVA, I worked in the Obama-Biden White House on the My Brother's Keeper initiative and on the White House healthcare team. So I worked at this intersection of health and social justice, and here I am reprising that role in a new capacity, taking on this pandemic. In my capacity as a senior policy advisor for equity on the COVID-19 response team, I really cut across all the different dynamics, all the different components of our COVID response. And that's certainly our testing effort, our vaccine effort, even some of our work in the supply chain, the education component, working with schools. Equity lives and breathes in every single dynamic within this pandemic, and it absolutely must. That's a requirement for our success in getting through this pandemic, is our commitment, our investment in addressing equity challenges. And so, I know that, as we say, I'm preaching to the choir here. You all know a thing or two about this, but if you'll indulge me, let's have a little bit of choir practice, because I think this is one of those moments where we can look at the data, we can see that we've got, mortality rates that are higher among some racial and ethnic demographics. We can see that we had a real uptake of cases in rural areas relative to urban areas. We can look at the impact of this pandemic on the disability community or folks based on sexual orientation or gender identity. We've seen that this pandemic affects different groups differently. So how can we design a strategy that's tailored to each group to make sure that they're getting exactly what they need? Well, the answer is that's the definition of equity. That's actually what the job is. It's to make sure that we have a response that acknowledges those differences, acknowledges how they can manifest in disproportionate rates, and intervene upstream of those challenges. And that's why it's so exciting to kind of lean into that work. President Biden has said time and time again, equity is the foundation of our COVID response. Our COVID response team lead, the coordinator of the COVID response team, Jeff Zients, says it pretty much every single time he comes on camera. He says equity is the center point of our response. And we mean that because we know that without equity, we're not going to get through this. I think what I'll talk about just to close, because I want to leave quite a bit of time for the conversation to ensue. But one thing to keep in mind is that there's a lot of focus on this concept of vaccine hesitancy right now. And the vaccination process is not at all the only dynamic of our equity conversation, but it's a pretty big one, because yes, we've had equity conversations around testing, around school reopenings, around all the different dynamics here in the pandemic. But the vaccine effort is kind of the light at the end of the tunnel. It's hopefully our way through this to get our communities to the other side, to protect people and to prevent death, which is the primary objective. And so in the vaccine effort, when we hear the term vaccine hesitancy, I always like to reframe it for people because we're talking about really three different things. The hesitancy, there's a great paper, this international group came together and said, what is vaccine hesitancy? Well, it's pretty alliterative. It comes in 3 C's. There's the complacency dynamic where folks say, hey, the risk of this virus doesn't outweigh the potential challenge of getting a vaccine. I'm just going to try my luck with the virus. There's the idea of confidence, and that's the safety and the efficacy. That's the trust in the systems and institutions administering the vaccine. And that's also the trust in the intent, the intention behind the government saying, hey, you should get vaccinated. If there's not trust there, if there's not confidence in those 3 areas, then it's hard to get folks vaccinated. And the last area is convenience, or that's kind of the access dynamic. And you all play a critical role in that access dynamic as well. For us in our COVID response, we've really focused on all of those, but in particular, the confidence and convenience dynamics. So on the confidence front, we're launching this month a national public education campaign to make sure we're getting the word out, make sure that all communities know what these vaccines are, kind of what's important about them, why they are life-saving, why we're making the recommendations we're making. You probably the news in the past couple minutes, the announcements about the Johnson vaccine, and it's really confused by efficacy rates and whatnot, but we want to make it really simple and just say these are life-saving vaccines and they do their job at saving lives really well. And so I think that's really important for us to get across to everybody. We're not splitting hairs between these 3. We have 3 life-saving vaccines that prevent severe illness, and we want to make sure those get into the arms of every single American. But making those communication points simple, leveraging trusted messengers, leaning into the well-worn paths that our communities already look to, that's the key. And I think that's something that we want to do well and that you all know how to do well. So we look forward to partnering with you on that. And then on the access piece, the convenience piece, of course, that's going to be one of the keys. We have quite a few different archetypes from the federal standpoint. We have our large mass vaccination sites. We have the retail pharmacies program. We have the federal qualified health centers program. We're launching our mobile units. So yes, we have a lot of different ways that we're rolling out vaccines federally, but also our partnerships with states and localities to make sure that we're assisting them in equitable distribution is also a key. So as you can imagine, my days are busy because this work is broad, but I think that this is a good problem to have for us to spend so much time thinking about how to do this equitably. It is actually, as I've said time and time again, it is our path through this pandemic is to focus on that equity dynamic, to make sure that those hardest hit, highest risk communities are getting what they need. And we're just so grateful that you all are committed to this, that you're invested in this, and that you're here for the work, because that's what it's going to require, all of us pulling together. So thanks for having me today. Thanks for the invitation, and look forward to the conversation.
Great. Well, thank you, Dr. Webb, for sharing your perspective, your thoughts, and making the health of our country a priority. I think we will all take the 3 C's away and make sure that we're applying them as well. So really appreciate you joining us today and all of the important work that you're doing, and we look forward to the continued partnership. In Tennessee, as around the country, COVID-19 has disproportionately impacted people of color and the communities where they live. So it's critically important that we distribute the vaccine that carry the hope of ending this crisis, and that we work hard to overcome any hesitancy among these very groups, and work to address the understandable mistrust and uncertainty they have about our healthcare system. So we'll now turn to our panel from Blue Cross Blue Shield of Tennessee and Meharry Medical College, who are driving solutions that address vaccine reluctance by using data to pinpoint areas where hesitancy may be of great concern. The panel will be moderated by someone that I think many of you know, Marilyn Serafini of the Bipartisan Policy Center. Marilyn, welcome, and I'll turn to you.
Great, thank you very much, Justine. So we've just heard a lot from Dr. Webb about vaccine hesitancy. And, you know, in some parts of our communities, we've got people scrambling to get out there and try to get appointments, but we have many others who are hesitant. So what now? How do we find those people who are hesitant and reach them in their communities? And this is what we're going to be talking about today. Our panel today is going to help us to understand this hesitancy, and they're going to discuss innovative steps that they're taking in trying to reach these people. So we're going to hear about an important partnership between Blue Cross Blue Shield of Tennessee and Meharry Medical College that addresses really head-on this hesitancy. And they're making some very interesting use of data. As you've heard from Justine, last year they came together to map communities in Tennessee using de-identified medical claims data, predictive analytics, and a social vulnerabilities index. So before I introduce our panelists, I want to just let everybody know who's with us today. You can submit your questions at any time during this discussion. We will leave time for questions at the, later on in our program. And I will, if you click on the Q&A button, you can send your questions in there, and then I will relay as many questions as we have time for to the panelists. So after we finish with the panel discussion, we will then turn to Emily Spain, who is Chief of Staff to Senator Tom Carper of Delaware, who will give us the latest from the Hill. So let's get to it. We have with us Dr. Andrea Willis. She is Senior Vice President and Chief Medical Officer for Blue Cross Blue Shield of Tennessee. Sherry Zink is Senior Vice President and Chief Data Officer for Blue Cross Blue Shield of Tennessee. And Dr. Brian Heckman, who is Director of the Center for the Study of Social Determinants of Health at Meharry Medical College. So Dr. Willis, let's start with you. Can you tell us about this partnership? What is this partnership about, and how did it arise? What are the problems you're trying to address?
Having us today to talk about this. This is very exciting for us. So at the very beginning of this COVID-19 crisis, I mean, certainly within the walls of Blue Cross Blue Shield of Tennessee, we were focused on the social determinants of health, and we were focused on health disparities. And we knew we needed to outreach to our most vulnerable members, our high-risk members. And that's when our information delivery department that Sherry oversees, helped us, the clinical staff, to basically have this social vulnerability index so that we would know exactly who to outreach to. And it was bigger than just high-risk condition. It looked at race and ethnicity data as well, and it looked at the resources that was in the area. And we would talk about these things in community type meetings. And in a lot of the meetings where I was, there would be leadership from Meharry as well. And I think that shows us like what public health really is about. It's about all of us bringing our resources, our strengths to the table so that we can really wrap ourselves around the people that need us the most. And I knew one of these days we would have the opportunity to connect with Meharry so that we could combine our data, our different perspectives, so that we could really make a difference. And you know what? That opportunity did come, and I'll pass it on to Sherry and let her talk about what that opportunity was.
Thanks, Dr. Willis. And welcome everybody today. This has been a great partnership with Meharry. One of the opportunities that we've had, and when we think about the social vulnerability index, is we were taking a look at that when we started our Power of We conference. And our Power of We conference at Blue Cross is just a conference that we have every year that focuses in on diversity and inclusion. And this year we felt like it was really important to point out those health disparities that we saw across the state of Tennessee, and to also point out those social vulnerabilities vulnerabilities that also play in to someone's ability to get healthcare appropriately, or maybe even their thought process and their trust of the healthcare system in general. And so that's how our Social Vulnerability Index came to be. And then in addition to that, in working with Dr. Heckman and his staff at Meharry, we were able to marry that with a lot of the data that they have around community information, as well as claims related information, to really get a good handle on where we saw vulnerable populations and what our opportunity would be to outreach to those populations.
Thank you. Sherry, can you talk a little bit more about vaccine hesitancy? Who are the people who are hesitant? We know that there are some groups that are more hesitant than others. For example, it's troubling that only 35% of Black adults and 42% of Hispanics say that they will get the COVID vaccine as soon as they can. And that compares to 53% of white adults. Blacks and Hispanics also say they're more likely to want to wait and see how the vaccine works with others. Give us the scope of who's hesitant and why.
Yeah, I'll start the conversation and then I'll definitely let Brian add to it. But I think what we see just in the population in general is just a lack of trust sometimes of just the healthcare system in general in certain populations. And we also see access issues. So for example, if someone has issues around transportation, they may be hesitant to get the vaccine. If there are language barriers, a lot of times we see with maybe the Hispanic population, there's a language barrier of really understanding what the vaccine is and being educated on it. And I think that's the important thing, is a lot of these vulnerable populations maybe don't understand how the vaccine really affects them and how it can help them. And then I think the other thing is just those barriers where they don't see a way to maybe get the vaccine. So let's say it's transportation issues, maybe they're focused on economic issues and they don't understand maybe that the vaccine is paid for, or how their insurance, or if they have lack of insurance. So again, making sure that we have that education in place. Those populations who have some fear factor, maybe they feel like that there wasn't enough, from a testing perspective, enough wide range of population. So again, I think that goes back to education and how that looks in the population. And I think what the Social Vulnerability Index does for us in conjunction with the vaccine hesitancy is it gives us an opportunity to look at those populations where those issues exist and really hone in and personalize the outreach that we're going to do in those communities. Rather than doing a general education campaign, there needs to be a pointed education campaign. The other thing that we also see with this, and I'm sure Brian will have some more to say about this, is educating the physicians that are out there taking care of these patients and helping them to understand, what are those, who are those populations that they have in their portfolio that they can really educate and encourage that they may not be aware of. So that's where we see a lot of that hesitancy going on. And Brian, I don't know if you want to add to that.
Yeah, and Brian, if you could also please add to that, and also help us to understand what the different data tools that you are working with and how you're using those tools together with data from Blue Cross Blue Shield to really identify the communities and the people who are hesitant.
Yeah, absolutely. And thank you all in attendance and for showing interest, and again for everyone on the panel here for our inclusion. It's been exciting to work with Blue Cross Blue Shield, and want to commend them for really kind of looking forward. So we kind of started this project many months ago, even before a COVID vaccine was available, while trying to look at this concept of vaccine hesitancy, because as you would imagine, we already know there's these disparate health outcomes. And now, as Marilyn aptly mentioned, there's also some disparities in hesitancy. So the gap of the actual disparities could actually get wider if we don't address this hesitancy quick and make sure that we do have equitable access and equitable vaccination rates, in addition to just getting the vaccines out there. In addition to some of the data that was already mentioned, we're also trying to integrate other data that is publicly available, like the CDC Social Vulnerability Index and some other vulnerability indices, that are nationally available, as well as some other Tennessee specific data, in addition to kind of just vaccination rates and all those types of things. One of the other variables I think is important that came through the Blue Cross Blue Shield partnership was being able to look at potential vaccination refusals in the past, which tends to be a large predictor of how people might respond to another vaccine when it is available. And fortunately, now we have 3. So kind of getting ahead of the cart in a way, in the sense of being able to identify factors that may have predicted vaccine refusal was our first step. So then we were able to kind of pinpoint different regions in Tennessee where we might anticipate vaccination becoming a little bit problematic. And so we're going to continue using that model to build on it. And then as the vaccine for COVID becomes more available, seeing to what degree that is useful in predicting it and how we can inform that model as we get more and more data streams coming in. So to me, I'm just super excited because I think this really represents like a blending of precision medicine and population health into a really impactful and unique way to make a public health impact and help enhance health equity.
So let's talk a little bit about the practical uses of this. How are you taking this information? I believe, if I'm understanding it correctly, you are mapping, and then what happens? I've heard reaching out to medical providers. How are you getting the information to the right people? Who are those right people exactly? And are you already doing this? Are you seeing results? Or what's going to happen here? And whoever's most appropriate to answer this question, please.
Have a piece of this, but certainly, as Dr. Webb had talked about earlier, I mean, we want to see our way out of this pandemic crisis. So we definitely want to use the information to make sure that we get people vaccinated, especially the people that need it, that are high risk. I mean, the people that we really want to make that sure that there's equitable distribution and access to the vaccine. So that would be the most immediate thing. But in doing this, we have community champions out there. We want to really embrace them. We want to make sure that we're giving them the support and data that they need to really get out there and do what they need to do. I think the beautiful thing about data is it's a language that everybody can understand. It's not anecdotal, it's not just narrative. It is true. Here are the facts, and here are the facts we can work with. And here are the measures that we can look at to see if we're making progress. And here are the ultimate outcome measures. So, you know, including physicians, policymakers, anybody that we can show that objective data to, not only does it help us get through the crisis right now, but it provides a platform where we can keep building even after this crisis is over. Like, we shouldn't think that the work ends with this.
Mm-hmm.
Yeah.
Oh, go ahead, Brian.
I was just going to say, one of the really nice, again, complementary natures of this relationship is for over 150 years, Meharry's been, the mission has been to focus on providing health access and equity. And so we have a very strong network of community engagement work where we kind of have community champions or trusted messengers already in place across the state. And so it provides different avenues, whether it's through the healthcare provider that might be accessible through the Blue Cross Blue Shield network, or community-based partners, whether it's through churches or schools or teachers or whoever that trusted messenger might be. It gives us a broader reach, and people might respond differently to different trusted messengers. So identifying who is each types of people's trusted messengers and being open to that flexibility, and also the content and modality with which the message is delivered. So we're also working on solutions that are digital apps or web-based, in addition to kind of the traditional kind of boots on the ground, face-to-face, but also kind of having a much more kind of scalable platform that, regardless of whether it's COVID or the next, hopefully not anytime near pandemic or any other health-related issue, that there are plenty that could be addressed through health disparities, that we have this infrastructure that could be employed to go well beyond and reach the most people possible in the most effective way possible. So And then I think Dr. Webb also mentioned kind of mobile units. So we've been reformatting different mobile units. So it could be ways, if we know there's different regions, now we know where to send the mobile units, for example, or now we know where to target some of the different types of messaging that goes out there, and maybe reformat how we do that messaging, because maybe it's not reaching everybody the way we intend, essentially.
Yeah, and I think the other important thing just to kind of think about that is, at the end of the day, when you can have all the data in the world, but you have to be able to act on it. And so I think the important thing is, if you look at the tools and technology that Blue Cross has at their fingertips, like, for example, a campaign management system that allows us to do multi-channel outreach. So if we need to text someone, if we need to email them, we can marry a lot of this data and findings that we have into those tools and technologies that allow us to launch digital communications or other types of communications much more effectively and deliver on that. And then I think just the relationships, as Brian pointed out, that we have with providers in our community, and the fact that we have a staff of people that meet with providers to educate them on other topics related to maybe gaps in care for their patients and things like that. This is just another avenue that would give us the opportunity to take that data and actually put it to good use out in the community. I think the other thing that's really important, and Brian mentioned the mobile unit. Of course, Blue Cross has a mobile unit as well. And then we also have the opportunity to go out and participate in other community events. So I think one of the great things about this is the mapping techniques that are being used, and the understanding of what communities are at the most vulnerable risk, and looking at those communities to say, how do we address that particular community in a unique way that is going to give us the opportunity to move the needle on that hesitancy index. So it's not going to be one size fits all for every community in Tennessee. I think it's going to be a very personalized approach. And that's what the vaccine hesitancy and the social vulnerability index give us the opportunity to do.
And I'm sorry, I'd be remiss if I didn't mention one other thing, but also making sure that those communities' voices are part of that, the way that things are changed. So we actually engage with them to understand, how to best provide that information. And so it truly is a community informed and community engaged type of approach. So.
Okay. Reminder that if you have questions, we're going to turn to questions in just a moment. You can send them in through the Q&A button on your Zoom. Sherry, you mentioned a number of times the social vulnerability index, which has 19 factors. Can you just, in a little more detail, can you explain what that is and how you all generate that number and that list?
Sure. So one of the things when we think about social vulnerabilities, there's a lot of different factors, food insecurities, economic stability, access to care, those types of things. And there's a lot of components that fit into those. So what we do is there are 19 what we would call social vulnerability or social determinants of health. Each person is assigned a value. So for example, if they have a vulnerability around economic stability and maybe access to care, they would get a higher score than someone who maybe has no issues at all. And what this really allows us to do is not only focus on that person's, health or what they need from a claims or healthcare perspective, but also how we can address those social aspects that are playing into their decision-making process, which I think is very important, because when we think about looking at the whole person, it's not just about, how they file a claim or going to the doctor. It's also about all the things that they're dealing with and just their normal day-to-day life that's creating maybe barriers for them from a care perspective. And so what the social vulnerability index does is allows us to address those issues in a more effective way, person by person.
And I think that, a lot of times that rolls up to the community as well, because when you look at social vulnerability, it looks at how a community can bounce back from things like, disease outbreaks, what we're seeing right now. And if the system is already at a tilt where they're going to have to fight really hard just to get the care that they need. They're at a disadvantage. And you can imagine if they're at a disadvantage just to get care that they need, it's really hard for them to win and progress and to be healthy beyond that. So I think it takes all of those things into account, and it's been very helpful.
Dr. Willis, it sounds like you're saying that this process could work for other health issues.
Absolutely. This is just a starting point. I think, unfortunately, the COVID crisis has been a perfect storm to really make us put our heads together to really work on this social vulnerability and what we can do around health disparities and social determinants of health. So it's a starting point that really made us coalesce in a meaningful way. And that's what we mean. We have some short-term goals, but certainly we have some long-term goals, because we cannot be done once this is over. It's just too important.
Thank you. Question from Sarah Solomon. How are you looking to social media to address issues of vaccine hesitancy that are widespread on those platforms?
There's probably several answers here. I'll just give one, and certainly Dr. Hedman, Sherry can join in as well. So at Blue Cross Blue Shield of Tennessee, we have used social media. We have a PSA out there. It's actually me telling why I want to get the vaccine. And it really is me stating my reasons. It's authentic. I'm grateful to our communications team for providing the channel, but really just letting me speak to what's on my heart. And I will say that is one of the beautiful things about having diversity within your workforce, because you really get to speak to other people that may look like you and don't feel like they have a voice, and they don't know that their concerns are being heard or being addressed. So that's one of the ways that we've used social media, and it has been very effective. I mean, it's been spread. I mean, people share it with other people, and we get feedback from that. So it's been a really positive thing.
Okay, great. We have another question. Does equity include getting the vaccine to the homebound elderly? How do we deal with that? Sherry, anything from your end?
Yeah, I think that, one of the things, and again, I think there's dynamics that play into here and being able to get that. But, when you look at, like, for example, a Medicare population or a population with Medicare Advantage, we do in-home services all the time. We have in-home doctors going there and administering assessments. We do home health care. So I think what we would want to do is, once the dynamics are worked out about how that is delivered effectively in the home, I think we would want to integrate that into all of the other home-based type things that we do for that Medicare population. The Social Vulnerability Index is created for all of the populations that we serve, with Medicare Advantage being one of those. And so again, I think being able to leverage that and take what we already know about how in-home services work well with the elderly population and apply that to the vaccine initiative, I think is going to be very important as we go forward.
Okay, so Dr. Willis, did you want to add to that?
Oh, no, I was just agreeing with Sherry and saying equity is the underlying principle there. And then you have to think about the logistics too, to really map it out to make sure no vaccine is wasted. So that is definitely being talked about.
Okay. All right. So we're going to turn now to Emily Spain. Emily is with Senator Carper. Emily, can you give us your update from the Hill? You've just heard us talking about vaccines, vaccine hesitancy, equity issues. Help us out. What are you hearing from the Hill?
Well, thank you so much for having me here today. And it's always great to work with Blue Cross Blue Shield, and you guys do amazing work. As I'm listening to the previous participants, all of these issues that you're talking about, equity, health disparities, these are things that we've really tried to tackle head on in this latest COVID relief package, but we're also building on the previous packages that we passed last year. So to channel President Biden and his Build Back Better agenda, you should think about this $1.9 trillion package that the Congress is considering as complementing what we've passed in the past year, and then hopefully addressing both the short and the long-term needs of our healthcare system. So we're going to put a lot of money out there very strategically to deal with some of these issues, whether it's vaccine hesitancy, a need for better healthcare surveillance, to identify future pandemics, making sure that we have healthcare workers in communities where we can provide access. All of these things, we're making both a short-term and a long-term investment. So the state of play for the package right now is that, as many of you might have read, the package was passed by the House of Representatives in the wee hours of Saturday. And late last week, there were a number of significant developments from sort of a procedural process view. One of the major issues that was a question mark in the package is whether or not there would be a move to raise the minimum wage. And while that provision raised the minimum wage to $15 an hour, while that provision was included in the House passed bill that passed on Saturday, the Senate parliamentarian has decided that provision is not germane under the Senate rules of consideration. And so there was a little bit of a flurry over the weekend to see if there'd be sort of a plan B for the $15 minimum wage, but it's been reported that folks have backed away from that. And that was one issue that sort of smooths the way for passing this package. I would say that there are still ongoing conversations with the Senate parliamentarian about different provisions of the House passed package to make sure that whatever piece of legislation we consider on the Senate floor will comport with the Senate rules for consideration under the reconciliation process. So that's an ongoing conversation, and there's still some provisions that have to be cleared by the Senate parliamentarian. As it pertains to timing, I think there's still an interest among some senators to see different tweaks here and there, maybe tailoring different pieces of the bill. But I think that we could see this package being on the floor for Senate votes as soon as the end of this week, like Thursday, or it could take a little bit of additional time to work through some of these issues with the Senate parliamentarian and with individual senators wanting certain provisions tweaked. It might slip to next week, but I think we're still on track to pass the package in the Senate and then get it back to the House before it goes to the president before this deadline of March 14th. And we want to do it by March 14th because that's when the enhanced unemployment benefits are set to expire.
Okay, thank you. So what is next from your perspective and your boss's perspective? What still needs to be done?
Yeah, I think that's a really good question. We've passed a number of really big bills, putting a lot of resources out there. And I think we want to see how things are working on the ground, and getting really good data to kind of inform what the next step is, I think is really important. There are different data metrics that we're tracking, some things like unemployment, but also, a really key point is, can schools reopen? Do people feel comfortable sending their kids back to school so then they can go back to work? So I think that what you'll see is a sort of a dual track for the next big piece of legislation. You could see through the reconciliation process another big sort of infrastructure and economic recovery package moving forward, or you could see smaller, more tailored bills that deal with individual pieces of infrastructure. But either way, I think that the next 6 to 9 months are going to be very busy in the House and the Senate as we continue to grapple with sort of the economic fallout from the pandemic. And then continue to refine our public health response to the pandemic, right? To continue to shift things, tweak things, do oversight to make sure the money is getting where we want it to go, and we're getting the biggest bang for our buck in terms of the money that we're spending. If there's certain programs that work really well to get people to take the vaccine, or certain states that are deploying the vaccine really strategically, we want to learn from them and mimic that those successful practices across the country.
Okay, so from your perspective, Senator Carper's office, what will you all be working on next?
Well, I think for our office, my boss is the chair of the Environment and Public Works Committee. And so we're very focused on the infrastructure piece of this package. And that does have a public health nexus. One of the things that we've seen is that in a lot of communities, they didn't have access to clean drinking water. And it's really hard if you're trying to wash your hands and stay healthy and do all of that if you don't have access to clean, reliable water. So I think and that's a bipartisan issue, frankly. A lot of rural communities deal with these issues, both in terms of tribal lands, but also just general rural populations. And so I think there is some interest in moving forward with a bipartisan sort of water infrastructure package. I think as it pertains to healthcare specifically, one of the areas of interest for a lot of Democrats, including my boss, is taking the Affordable Care Act and strengthening it. One of the things that we really love to see that the administration did was that they expanded the enrollment period for getting healthcare plans through the Affordable Care Act. So folks who had lost their job perhaps could enroll and find an affordable plan. There's additional things that we can do to, again, bolster the Affordable Care Act, bring down costs for consumers, and increase coverage. And that's something that I think that there's a lot of interest in acting on that in the coming weeks and months too.
So Emily, you use the word bipartisanship or bipartisan, and being with the Bipartisan Policy Center, I can't let you go without asking you more about bipartisanship on the Hill. You've talked about some legislation that's under negotiation and various aspects of that. What is the bipartisan mood like up on the Hill right now, and what is possible?
Yeah, I think that's a really good point. I mean, I think that folks from the outside always say, "Oh, it's so bad up there. It's so partisan." But when we're up here in the day to day and talking to our friends and colleagues in other offices, I still think there is a strong interest in bipartisanship. And I would point to the previous recovery package that was a bipartisan package that was put together in December of last year as a good roadmap. We are able to come together and address some of these issues in large pieces of legislation. But I also think that there's a pent-up desire to legislate in a bipartisan way. And Joe Biden, President Biden, is someone who he just brings people together and he infuses everything that he does with that style of leadership. And I think there's a real hunger on the Hill to getting back to doing things together. And so I think that, last Congress, before the pandemic, we really didn't do a lot of legislating. We did in the entire Congress, we hadn't done any budget reconciliation type bills, and there were very few bills that came to the floor for a vote. Now, the pandemic spurred us all to action. We passed a number of large pieces of legislation, but I think there is a pent-up demand to actually enact legislation. And I think there are a number of things, including in the healthcare space, like, for example, telemedicine, and is an area where there's a lot of bipartisan interest. We've seen it's become a necessity during the pandemic, and that's really, I think, heightened people's interest in this area. I also think that as our economy has changed a little bit because of the pandemic, helping folks retool, if maybe they lost their job in one sector and they want to retool and get new skills, the healthcare industry always seems to be hiring, and there's an enhanced need for healthcare workers. So that's another area where I think you can see some bipartisan cooperation and collaboration. So I personally am hopeful. I tend to see the Congress with a glass half full, if you will. And so I think you'll see some bipartisan legislation get enacted this year.
Great. Well, thank you very much, Emily. Really appreciate your input and appreciate the panel. I'm going to turn it back over now to Justine for some closing remarks.
Great, thank you, Marilyn. And really just appreciate the panel discussion today. I think as we've heard, there are clearly, while many issues that we face in terms of vaccine hesitancy and equitable distribution, you also see that there is a lot of great work underway on solutions to get us where we need to be. We know how busy everyone is, so do want to be respectful of your time, but really want to thank everyone for joining us today. Certainly don't hesitate to reach out if there's ways that we can help. as we want to continue to be partners as we work to end this pandemic. And Kim, I see you've joined as well. Are there some closing remarks you might want to make?
And I've been here the whole time. I just, out of respect, put my camera off so we could have the attention where it needed to be. But I would just say thank you. I'm proud to hear all of these conversations. This one in particular about the great work that Tennessee is doing, and hopefully I'll call it template or model of sort that I hope we can build on across the Blue plans, because it's such important work. And sometimes I feel badly about the fact that we're just starting some of this work in 2021, given the fact that disparities are, decades in the making. And yet, on the other hand, to use the expression that one of our colleagues in Tennessee used earlier, look, we have to be glass half full and really look at this as an enormous opportunity in which we can build. And so I'm proud of the work that you all are leading. Thank you for leading it and for the conversation and for everyone joining today. Look forward to continuing the dialogue. I can't wait for the time we can do it in person and we can actually exchange ideas in a way that doesn't require us to look at these tiny little dots on our PCs, but that'll be here soon. So thanks everyone for being with us today. And with that, I think we're a wrap.
Yes, thank you everyone and have a good day.
Thanks everyone.